So let's talk about blood physiology. Here we are going to learn the following. We are going to learn the components of blood tissue. We're also going to learn the morphology and functions of erythrocytes. The erythrocytes are the red blood cells. Erythrocytes are red blood cells. We are also going to learn the indices which are used to characterize the red blood cells. We will talk about blood group, and we'll clarify on a few concepts of blood transfusion. We'll also define anemia and give various categories of causes of anemia. And lastly, we'll talk about white blood cells. We'll say their varieties and their functions. I believe the last two, most likely you've already done okay, maybe the last one and number 4, you've already done in your immunology. So just have it for the sake of completion. Now, blood is considered a specialized connective tissue. We consider blood a specialized connective tissue because this type of connective tissue has a fluid matrix. Remember, the other connective tissues don't usually have fluid matrix, but blood has a fluid matrix. That's why we consider it special. That's what makes it special. Blood is important for transport of substances. These substances could be gases like oxygen and carbon dioxide. It also transports nutrients, waste products, and even hormones. Apart from transport function, blood is important for defense against infection. This can be either through humoral immunity, which is defense by use of antibodies, and cell-mediated immunity, which is defense by use of cells that kill others. Blood is also important in regulation of blood potential hydrogen. The potential hydrogen, pH, is usually regulated by 3 organs in the body. We have the kidney, which regulates pH. We also have the lungs that regulate pH. And the third one is the blood. We can consider blood to also be able to restrict fluid loss at injury sites. This is through the mechanism of blood clotting. If you injure a blood vessel, blood will clot there so that you don't lose a lot of blood, so you don't lose fluid. Lastly, blood is important in thermoregulation through the act of cutaneous vasodilation and cutaneous vasoconstriction. These are the key functions of blood. So what are the components of blood? We can look at the components of blood in 2 ways. We have the plasma. The plasma refers to the liquid component of blood. And the other component of blood is what we call the formed elements. The formed elements refer to the cells of blood. So we have blood cells and you have plasma. Let's begin with the plasma. As I've mentioned, plasma is the liquid component of blood. Plasma contains a number of things. It contains nutrients which are being transported. The plasma proteins themselves, these plasma proteins are largely produced by the liver. They include globulin and albumin. We also have electrolytes such as sodium, potassium, calcium, and the like. We have hormones like adrenaline, thyroid hormones, and the like. We have waste products such as urea, creatinine. They're all within plasma. There's a term that sometimes we use, and it's important that you understand what it means. That term is serum. Serum is plasma without clotting factors. So we get serum after blood has been withdrawn and allowed to clot. If you allow blood to clot, now the liquid that you get from a clotted blood is what we are calling serum. We are saying it doesn't have clotting factors because those clotting factors have already been utilized in clotting the blood we are talking about. And so you're just taking the water part, that liquid part of blood. So serum is blood without clotting factors. From a clinical point of view, serum is largely used because it contains antibodies. When you allow whole blood to settle, whole blood means that blood that has not been clotted. If you allow whole blood to settle, that whole blood will form 3 layers. The lowermost layer is occupied by the red blood cells. This is because the red blood cells tend to be denser. So they occupy the lower zone. That lower zone occupied by the red blood cell is what we call the packed cell volume. The packed cell volume is about 45% of the whole blood. You can add or minus 2% on that. That is still within normal range. Then topmost is the region occupied by plasma. Plasma, as we've said, is the water component, the liquid component of blood. That is plasma. It is the least dense of the 3 components we're talking about. And so this one will occupy the topmost part of this spectrum. Plasma is about 55% of the whole blood. Then we remain with a very thin strip, which is less than 1%, which we call the Buffy coat. The Buffy coat represents the region occupied by white blood cells as well as the platelets. Very thin layer. Either way, the white blood cells, the platelets, and the red blood cells constitute the formed elements of blood, and the plasma, all these now constitute blood. So we can now talk about the formed elements of blood. The formed elements of blood refers to the cells of blood. So we have erythrocytes, which are the red blood cells. These are the majority. Then we have the leukocytes, which are the white blood cells. And lastly, we have the platelets, which are also known as thrombocytes. I believe we all know the functions of platelets. They are important in blood clotting. So blood clotting. All right, let's talk about the red blood cells. Red blood cells morphologically are biconcave discs. This is to mean that they are concave on both sides. As you can see here, the central part is a bit thin because the cell is biconcave. Red blood cells do not have a nucleus. The reason why they don't have a nucleus is so that you create more space that can be occupied by hemoglobin. Hemoglobin being the structure that usually bind oxygen. And so therefore we say that red blood cells are responsible for transporting oxygen. That's their key function. Where do we form the red blood cells? Red blood cells are formed in the bone marrow. Formation of red blood cells in the bone marrow is what we call intramedullary erythropoiesis. After birth, the normal site of formation of red blood cells is the bone marrow. However, there's some conditions that might affect the bone marrow so that the bone marrow is not able to produce red blood cells adequately. In those circumstances, people can be adapted by then recruiting other sites to produce red blood cells. And principally, the sites that can be recruited are the spleen, the liver, and some lymph nodes. In those circumstances, blood is then produced in those areas. We call that extramedullary hemopoiesis or extramedullary erythropoiesis. When you talk of hemopoiesis, you mean blood formation. When you talk of erythropoiesis, you're specifically referring to red blood cell formation. For bone marrow to produce red blood cell, it needs a stimulant. The stimulant here is the hormone erythropoietin. Erythropoietin is produced by the kidneys. The stimulus for production of erythropoietin is low oxygen tension. So when you have low oxygen tension, the kidney produces erythropoietin. Erythropoietin then acts on bone marrow to stimulate red blood cell formation. This is the reason why, like our athletes will prefer to then practice in highlands, because we know that highlands have low oxygen tension. So when you have that increased need for oxygen, the kidney is stimulated to produce erythropoietin. So that natural erythropoietin is what now help them to have a longer tenacity when they are on the field, maybe on a marathon. Of course, you don't also forget that some people can then misuse this drug. This is the drug that is usually misused by the athletes. But naturally, it's acceptable. The normal lifespan of red blood cells is about 3 to 4 months. So after 3 to 4 months, the cells become old and they are destroyed, principally by what we call the reticuloendothelial system. The reticuloendothelial system refers primarily to the liver and the spleen. These systems are the ones that destroy the worn-out cells and remove them from the circulation. Even though they're destroyed and removed, there are some components of the red blood cells which are recycled. And primarily the iron part of the hemoglobin is recycled. The iron component of hemoglobin is usually stored in the liver in form of what we call ferritin. Well, there's another component that is excreted, that is the bilirubin part of the heme. It will be excreted through bile. It explains to you why when someone is getting a lot of hemolysis, then they can turn yellow. They can get jaundice. What are some of the indices that we use to describe red blood cell? I'll teach you 5 of them. The first index is what we call hematocrit. The hematocrit is the same as the packed cell volume. So we get hematocrit by allowing whole blood to settle. Then we look at what percentage of whole blood is occupied by red blood cells. So by definition, hematocrit is the proportion of whole blood that is occupied by the red blood cells. You can call it the packed cell volume. We have red blood cell count. As the name suggests, red blood cell count is the total number of red blood cells, usually in 1 liter of blood. The total number of red blood cells per a liter of blood. These are the units for both male and female. You take that, you multiply by 1 million. You get the actual amount in males as well as in females. So as you can see here, the males tend to have a higher red blood cell count compared to female. Hemoglobin, otherwise known as HB, is also another parameter. This parameter is measured in grams per deciliter. It basically refers to the amount of hemoglobin in 1 deciliter of blood. And again, these are the units. The men tend to have a higher amount of hemoglobin compared to women. Sometimes you might be working in a lab that does not have the capacity to measure hemoglobin. It's not a big deal. You can always estimate hemoglobin from hematocrit. We do this estimation by dividing the hematocrit by 3. So if you divide that by 3, you'll almost get that one. And if you divide this by 3, you'll definitely get that one. So hemoglobin estimate, it's not actual, it's just an estimate, is gotten by dividing packed cell volume by 3. That means if someone has a PCV of 30, then you expect their HB to be 10. If they have a PCV of 54, then you expect their HB to be around 18. Okay. There are other parameters which don't really change between male and female. One of them is the mean corpuscular volume. The mean corpuscular volume refers to the size of a single red blood cell. So the size of a single red blood cell does not change whether you're male or female. By definition, it's the average size of a single red blood cell. Corpuscular refers to the cells. The mean is the average. We measure this in femtoliters. The last parameter is what we call MCH, mean corpuscular hemoglobin. This is the amount of hemoglobin in the average amount of hemoglobin in a single red blood cell. The average amount of hemoglobin in a single red blood cell. We measure that in picograms. And those are the units. Again, they shouldn't vary between male and female. So there's some circumstances where the size of a red blood cell can be very big. Then we call that macrocytosis. There are also circumstances where the size of the red blood cell can be too tiny, and we call that one microcytosis. So you can come across the term macrocytosis and microcytosis, or it can be given in their adjective form. So we talk of macrocytic and microcytic. You need to be familiar with those terms. These are the red cell indices. Now let's talk about blood grouping. So blood group basically refers to the presence of antigens on the outer surfaces of red blood cells. Which kind of antigens are we talking about? There are many antigens present on the cell membrane of red blood cells. But the antigens which are of clinical importance, and so the ones that are of medical importance, are two types of antigens. We have the ABO antigens and the rhesus antigens. Let's start with the ABO antigens. The ABO antigens are actually two antigens only. This is what we call antigen A, and this is what we call antigen B. So an individual might have antigen A on their red blood cells, and they don't have antigen B. That person will be classified as blood group A. An individual might have antigen B on their red blood cells, and they don't have antigen A. That person will be classified as blood group B. Another individual might have both antigens, and so you classify them as blood group AB. And another individual might not have any of the antigens. Then you call that blood group O. That O actually refers to 0, which means there's none. So that in terms of the blood groups, we have those 4 blood groups based on the ABO antigens. Something that is worth noting is that if someone is blood group A, it means that they have the A antigens. They will not have the antibodies against A, but they will be having antibodies against B. So you're looking at the red blood cells, yes, but you're also looking at the plasma or the serum of this individual, this same individual. An individual with A antigens on the cell membrane will be lacking antibodies against A on their serum, but they'll be having antibodies against B antigen. And you can argue that it's because of the presence of the antibodies against B, that now we don't have the B antigen here. And similarly, for someone who is blood group B, you can argue that the reason why they're lacking the A antigen is because they have antibodies against the A antigen. And someone who is blood group AB, that is only possible because they do not have any antibodies against those antigen. And someone with blood group O, you can argue that they have both antibodies present in their serum, and so they don't have those antigens. The ABO antigens are a bit unique in the sense that if an antigen is lacking, then the antibody must be present. And if an antigen is present, then the antibody must be lacking. That is about ABO antigens. And so when you're thinking through blood transfusion, the things to consider are largely the antigen of the donor and the antibodies in the recipient, because the antibodies in the recipient are the ones that are going to attack the antigens of the donor. So you don't have to look at the antibodies of the donor, because those ones are not helping much. You are looking at the antigens of the donor against the antibodies of the recipient. And that is why, therefore, we consider the AB antigen, the AB blood group, as a universal recipient. What makes the people with blood group AB be universal recipient is because they don't have any antibodies in their system that would attack the antigens which are coming in. I told you for the recipient, you look at the antibodies. Why do we consider someone with blood group blood group O as a universal donor? We consider blood group O a universal donor, again, because if you're blood group O, it means that there's no antigen on the red blood cell. So wherever that blood group goes, there's no risk of it being attacked by the antibodies of the recipient. That is why Blood group O is a universal donor. Blood group AB is a universal recipient. Okay, we can now talk about the rhesus antigens. There are multiple antigens which belong to the rhesus category. We have antigen E, we have antigen D, and we have antigen E, for example. And we can keep to those three. Antigen, what did I say? Antigen C, antigen D, and antigen E. Those are rhesus antigens. However, for us to classify you as being rhesus positive, that definition is based on the presence of the D antigen. So the rhesus positivity is defined by the presence of the D antigen. That means that if someone has antigen C in the red blood cells, but they don't have antigen D, they are still classified as being rhesus negative. And if someone has antigen D on their red blood cells, even if they lack C and E, they are still considered rhesus positive. So the D antigen is what determines rhesus positivity, because this is the one which is of clinical importance. Something different from the ABO antigens is this. Those people who are rhesus negative, you know, in ABO antigen, if someone doesn't have an antigen, they definitely has the antibody against that. That is not the same for rhesus antigens. If someone is rhesus negative, it means they don't have the D antigen. They do not necessarily have the antibody against D. They can only get the antibodies against the D antigen if they are sensitized. So they must have some exposure to the D antigen before they get that kind of antibody against D. Otherwise, they don't have the D, the antibodies against D. However, if someone is rhesus positive, definitely they don't have the D antigens. Right, now we can talk about anemia. What is anemia? Well, there are many definitions of anemia. Mara, you want to say low blood volume and things like that. But the accurate definition of anemia is a reduced oxygen carrying capacity of blood. If the blood has a reduced oxygen carrying capacity, then we call that anemia. What will make the blood have a reduced oxygen carrying capacity could be multiple. Therefore, there are multiple causes of anemia. Now, sometimes the definition of anemia must also be based on the gender, the age, and even geographical location of a person, or even the race sometimes. But let's not go into those nitty-gritty detail. Anemia is a reduced oxygen carrying capacity of blood. There are many causes of anemia. Let's look at some of the causes of anemia. We can classify the causes of anemia as follows. Someone can be anemic because the number of red blood cells in their circulation is low. So this is reduced red blood cell count. Instead of those units I gave you of 5.4 times 10 power 6 per liter of blood, maybe they only have 2 million per liter of blood. So we have reduced red blood cell count. Think through it. What can make you not have the normal number of red blood cells. The normal number of red blood cells can be low because you've lost blood. So you've bled, basically. Anemia due to blood loss is what we are calling hemorrhagic anemia. And the multiple causes of bleeding. It could be someone has been involved in a road traffic accident and so they have bled. It could be that someone has ulcers which has ulcerated and so it's puncturing a blood vessel, so they're bleeding slowly. It could be someone has a tumor on the GIT, like let's say colorectal cancer, that is bleeding, and so that also can cause anemia. Or it could be that they're just hemophilic. All this can cause anemia due to hemorrhage. The other cause of reduced red blood cell count is if you're not producing enough of the red blood cells. So reduced formation of red blood cells. Why would we have reduced formation of red blood cells? Can have reduced formation of red blood cells if there's a problem with the bone marrow. So these diseases that can affect the bone marrow, there's some parasites that can infiltrate the bone marrow and so denature the bone marrow. Those parasites can cause anemia due to a reduced blood formation. Such kind of anemia is what we call aplastic anemia. Anemia due to bone marrow destruction is called aplastic anemia. Lastly, you can have reduced red blood cell count because the red blood cells are being destroyed prematurely. There is increased destruction of the red blood cells. Perhaps they're being destroyed even before 2 months, before 1 month, maybe after a week, they've already been destroyed. The death of red blood cells is what we call hemolysis. So when the red blood cells are just undergoing hemolysis, it can give you anemia. And such kind of anemia are the ones we call hemolytic anemia. Could be genetic predisposition, could be some infections like malaria parasites can cause hemolysis. So these are anemia due to reduced red blood cell count. You can also have anemia due to insufficient hemoglobin content. The hemoglobin within the red blood cells is low. So maybe the red blood cell count is normal, but the amount of hemoglobin within the red blood cells is low. Possible causes of this include iron deficiency. Iron is important in the synthesis of hemoglobin. And so when iron component is not there, then the hemoglobin will not be synthesized. The red cells need this iron for them to synthesize hemoglobin. Therefore, if there is iron deficiency, you will have less hemoglobin within the red blood cell. We call such kind of anemia iron deficiency anemia. This kind of anemia are the ones that will also present with microcytic picture, where the cells will be very tiny. Vitamin B12 deficiency can also give you abnormal or rather low hemoglobin content. We need vitamin B12 for the synthesis of hemoglobin as well. And so if there is no vitamin B12, you'll have less content of hemoglobin within the red blood cells. Now, vitamin B12 is usually obtained in the diet, but for our bodies to absorb vitamin B12, we need something that is produced by the stomach. We call it the intrinsic factor. This intrinsic factor binds with vitamin B12 that is in the diet and then promote its absorption by the small intestines. So think about it. If you have a problem with the stomach, maybe that problem has led to the destruction of the cells that usually produce intrinsic factor. Maybe they are destroyed or they have been eliminated. Either way, we don't have intrinsic factor. If there's no intrinsic factor, then it means this individual cannot absorb vitamin B12. And if they can't absorb vitamin B12, then it means they will be anemic because they'll have low hemoglobin content. That type of anemia, which is due to elimination or destruction of the cells that produce intrinsic factors so that you now have vitamin B12 deficiency, is what we call pernicious anemia. The third category of causes of anemia would be if you have an abnormal hemoglobin. So look, the number of red blood cells is normal. The amount of hemoglobin is normal. What is abnormal is the structure of the hemoglobin. If the structure of the hemoglobin is abnormal, there's some kind of hemoglobin that are not efficient in carrying oxygen. And so those kind of hemoglobin will also give us a reduced oxygen carrying capacity. And that's why we still consider them as anemia syndromes. A good example of anemia due to abnormal hemoglobin content is sickle cell anemia. In sickle cell anemia, the individuals have a particular hemoglobin, which we call HbS, hemoglobin S. Usually we write it as H uppercase, B lowercase, then S uppercase. A normal individual needs to have what we call HbA, H uppercase, B lowercase, A uppercase. The A stands for adult, as opposed to in fetal life where we usually have HbF, F for fetal. So there are different types of hemoglobin. HbF and HbA are normal depending on the age of the individual, but HbS is abnormal. This HbS usually has a lower potential of carrying oxygen, and that's why these patients are also considered anemic. Great. I want to give you another break, maybe just 2 minutes as I drink water. Let's now proceed with the white blood cells. So white blood cells, I believe you've done this in immunology. I'll just highlight on what I want you to know from a physiology point of view. So basically what I'll be addressing is way little compared to what you know in immunology. But let me highlight what we want you to know as with regard to the unit of physiology. We know that there are two categories of white blood cells. There are those that we call granulocytes, and there are those that we call the agranulocytes. This classification is based on the presence of granules within the cytoplasm of the white blood cells. There are those that contain granules within the cytoplasm, and there are those that lack granules within the cytoplasm. Let's start with the ones that contain granules within the cytoplasm. Remember, these granules contain various chemicals like histamine, leukotrienes, and the like, which can be released to mediate inflammatory reactions. Granulocytes are of three types. We have the neutrophils. These are the majority of the white blood cells, and therefore by default, the majority of the granulocytes. Neutrophils consist of about 50 to 70% of all white blood cells. So they're the majority. Their chief mechanism of action is by phagocytosis. They engulf infections which are extracellular, their major target being bacterial infections. So neutrophils offer immunity against bacterial infections largely, and their mechanism of action is phagocytosis. They are phagocytic cells. Compare that with basophils. Basophils are perhaps the least in the circulation. They are less than 1% in the circulation. They're the least. Basophils release their granules to mediate allergic reactions. Basophils are not limited to the blood circulation. When basophils leave the blood circulation, they become what we call mast cells. But they have similar functions. They act by releasing their granules, and these granules then mediate allergic reactions. Usually, they'll bind to antibody E so that they can mediate these allergic reactions. There are different types of mast cells depending on where they're found. The ones found in tissues are called connective tissue mast cells. And then the ones found in body surfaces are the ones we call mucosal mast cells. Remember, basophils is the name we give them when they're in the bloodstream, and mast cells is the name we give them when they're in the tissues. Basophils constitute less than 1% of all white blood cells. They're the least. The third type of granulocytes are the eosinophils. Eosinophils are about 2 to 4% or 1 to 4% of all white blood cells. Eosinophils also release their granules. They offer immunity against large pathogens, things like worms or some protozoal infections. Remember, these are the ones we call parasites. So eosinophils offer immunity against parasitic infections. Therefore, whenever we have parasitic infections, you expect eosinophilia, increased number of eosinophils. Whenever we have bacterial infection, you expect neutrophilia, which is increased number of neutrophils. These are granulocytes. How about the agranulocytes? The agranulocytes are two varieties. You have the monocytes and the lymphocytes. To start with the monocytes, monocytes are phagocytic cells. We call them so when they are within the bloodstream. But when they leave the bloodstream to go to various organs, we can just call them macrophages. Their key mechanism is in antigen presentation. They present antigens to T cells. Well, they have other mechanisms of action that contribute to immunity, but among them is the antigen presentation. Remember, there are different types of macrophages depending on the tissue where they are found. For example, the macrophages found in the skin are the ones we call the Langerhans cells. The ones found in the spleen and lymph nodes are the ones we call the dendritic cells. The ones found in the central nervous system are the ones we are calling the microglial cells. We name them according to where they're found. The ones found in the lungs are the ones we're calling the dust cells. They are antigen presenting cells. The other type of agranulocytes are the lymphocytes. Lymphocytes are of three varieties. We have the B lymphocytes. B lymphocytes are called so. The origin of the name was actually based on studies which were done in birds. And it was discovered that these B lymphocytes were maturing in a structure called the bursa of Fabricius. Humans don't have the bursa of Fabricius, but we have a bursa of Fabricius equivalent. The bursa of Fabricius equivalent in humans is the bone marrow. Coincidentally, they both begin with B, and so it's okay, we can just call them B cells. So you might sometimes think that the B cell is because they mature in the bone marrow. That is still true, but except in terms of the genesis of the name, it's because they were maturing in the bursa of Fabricius equivalent, in the bursa of Fabricius, which was in birds. So the equivalent of that is still bone marrow in humans. It's a good coincidence, we can go with this. B cells, when they are stimulated, they differentiate into two categories of cells. There are those that we call the B memory cells. These ones retain immunological memory of infections. So they're the ones that will explain the basis of vaccination. The other type of B cell is the plasma cell. What I mean is that B cell can differentiate into B memory cells as well as into plasma cells. Plasma cells are B cells which have been now stimulated to produce antibodies. So plasma cells produce antibodies. For that reason, we usually say, therefore, that B cells mediate humoral immunity. Humoral immunity is immune response by antibody production. The last one, or rather second last, the second type of lymphocytes are the T cells. T cells are called so because they mature within the thymus, so T for thymus. There are different varieties of T cells. We have the T memory, T cytotoxic, T helper, T regulatory, and the like. And they have different functions. Particularly, the T cytotoxic cells kill cells which are infected or cancer cells. That kind of immune response is what we call cell-mediated immunity or cellular immunity. Therefore, T cells mediate the cellular immunity. This is the type of immune response that is primarily mounted for intracellular infections, such as the viruses. Now, understand that all blood cells are produced by the bone marrow, but T cells, after they have been produced by the bone marrow, they are transported to the thymus where they mature there. That's the site of training of the T cells. B cells are produced in the bone marrow, but they also mature in the bone marrow in humans. The third type of lymphocytes are the natural killer cells. These are cells that kill indiscriminately. They offer immunity against tumor cells and against some intracellular infections as well, especially the ones which are not linked to major histocompatibility complex proteins. You see, the T cells are very specific. They can only kill cells which are linked to the major histocompatibility complex proteins. That is what we call T cell restriction. But these ones, even without the major histocompatibility complex, they can still kill. They also offer immunity against cancer cells. Right, so that's what I wanted to know about white blood cells. I forgot to tell you that the lymphocytes constitute about 20 to 40% of all white blood cells, and monocytes constitute about 2 to 8% of all white blood cells. I think I gave you the differential count for the other white blood cells. So there's a question here for you. I am not so sure whether it's available in the poll. Let me check it out. No, it's not available. It disappeared somewhere. But you can look at it and make your decision. You don't have to write in the chat. I think it's straightforward. So basically, immunoglobulin A is usually found on body surfaces and in secretions. So it is true it offers mucosal immunity. Immunoglobulin G is the most abundant of the antibodies. Apart from fixation of complement system, immunoglobulin G also has other functions. It is an opsonin. It causes opsonization. Opsonization is to make something more palatable for phagocytosis. So immunoglobulin G does that. Immunoglobulin G is also the only antibody actually that crosses the placenta, which means that although produced by the mother, immunoglobulin G is able to offer fetal protection. Immunoglobulin M, I forgot to tell you that immunoglobulin G is the immunoglobulin also that is released in secondary immune response. So it's the immunoglobulin for the secondary immune response. Immunoglobulin M is the immunoglobulin that tend to be released for primary immune response. It also fixes the complement system actually. And immunoglobulin M is the one that is produced by the fetus. That means that it also offers fetal protection. But remember, this one is being produced by the fetus. G is crossing the placenta from the mother to the fetus. They both offer fetal protection. Immunoglobulin E is the least amount of hemoglobin, is the least hemoglobin found in the circulation. The percentage is the least in the circulation. This one usually mediates allergic reactions by binding to mast cells and basophils. I believe you've done things about hypersensitivity reactions, and so you know about type 1 hypersensitivity reaction, where immunoglobulin E is particularly involved. And so this would be the correct response to this question. Immunoglobulin D, the function is not very clear really, but mature B cells usually have immunoglobulin D on its surface, and so it's believed that it can function as B cell receptor. Great, so that's the story. I think I've already taken you through that. Let's finish with the hemopoietic pathway. So this is the pathway of formation of blood cells. All blood cells are being formed from the bone marrow. We've agreed on that. The stem cell that forms the blood cells primarily differentiate into two lineages. We have the myeloid series and the lymphoid series. The lymphoid series is the one that gives us the lymphocytes. All of them, the lymphocytes, come from the lymphoid stem cell. But we also have the myeloid stem cell. The myeloid stem cell now gives us the other types of blood cells. It gives us megakaryocytes that become the platelets. It gives us the red blood cells. It gives us the granulocytes that will now have those three types. And it gives us the monocytes, which become the macrophages. So myeloid series gives us the other types of formed elements of blood. Lymphoid series gives us the lymphocytes. Great, so that's what I had for you today. I think we'll stop there.